forward for us. I think you're still on mute, Kelly.
Okay, I'm just trying to, where is the slide?
You're good. Go ahead and go to slideshow. You can either do on the bottom or on the top, that slideshow tab.
Yeah.
In the like red part of the tabs next to like home, insert design.
Yeah, this is, there we go. Thank you. The taskbar for this was covering it. So.
Oh, I know. I hate that.
I know. I'm like, wait, where is it? I know it's up there. From the beginning. Okay, is that good? Can everybody see that?
Yep, it's perfect.
Okay, excellent. So reactive attachment disorder. I'm not sure what comes to mind when you hear this diagnosis, right? If anyone, I really want, first of all, I would like this to be a very open discussion. This is an area of interest for me diagnostically, because I do believe that it's not diagnosed because people do not feel comfortable providing this diagnosis. But I do believe that we have a lot more kiddos who would meet criteria for reactive attachment if more practitioners would feel, comfortable diagnosing the reactive attachment. There we go. So today, just the overview is what is reactive attachment disorder. A brief introduction of like why it changed, because it did change from the DSM-4 to the 5 and how they separated the diagnosis. And then we're just going to kind of review that quickly because my slides are pretty dense, and I know, do I have the whole hour or just a half hour, Elizabeth?
You have the time. Yeah, we don't have a case today, so you're good.
Oh, okay. All right. Still, there's a lot in there. So I just want to really hit the highlights with it. And what I particularly want to pay attention to is the different the differential diagnoses with this, right? And how reactive attachment disorder can look like so many other things that I think practitioners feel more comfortable diagnosing. And please just jump in and unmute and just give me kind of your thoughts when you hear, oh, this kiddo is diagnosed with reactive attachment disorder. What kind of thoughts come to mind? Anybody?
Well, I think that when I hear it, and we do see this a lot in PBS, there's some type of disruption during those early years of attachment and when that attachment is developing. And so reactive attachment, I know there's several layers to it, but I think of some type of disruption to when that child is supposed to be, developing that attachment to their caregiver.
Okay, excellent. That's perfect. That's really, you summed it up very well. What do you think most people think, like that kiddo who's diagnosed with reactive attachment will present like?
I know that when I hear it, I think of trauma, and I think of a very externalizing child who's going to be difficult to manage. And unfortunately, I think of a kid who probably has a very poor trajectory, unless we get help pretty quickly. But I unfortunately see them when they end up in the juvenile justice system or the adult system, and I'm like, man, this was reactive attachment years ago.
Absolutely. Thank you, Dr. Lillard. That's absolutely perfect for what I'm going to try to share today, is that reactive attachment, I think for a lot of folks brings to mind, and forgive me of the word, but it's kind of a scary kid, right? I know a lot of people who have adopted children, and one of the things that they say they do not want is a kiddo diagnosed with reactive attachment. And most likely they are getting a kiddo who has reactive attachment, but just not diagnosed. And I think a lot of practitioners, again, like I said before, are a little scared to give that diagnosis because of that image, right, of reactive attachment that we kind of have, you know, as a society. So reactive attachment, both Heather and Dr. Lillard, you define this perfectly. It's, you know, aberrant social behaviors in a young child, basically from grossly negligent parenting, okay? That can be in a lot of different forms, right? That can look like the child may have two parents in the home, but they may be substance using, right? And so the child is neglected. They could have one parent or like a whole family living with them. So they technically have adults or grown-ups or someone in the home, but those grown-ups are not attending to the needs of that child. So understanding kind of what that looks like from the beginning helps us to understand if this could be kind of a disrupted attachment, right? So again, it's linked to the caregiving deprivation of the child. And, you know, we'll go into some more of the specifics of reactive attachment later on in the slides, but you see that kids who have reactive attachment are difficult to console. They're difficult to discipline. Like kiddos with other traumas, right? They live in that fight, flight, or freeze mode all the time, okay? And they have a strong desire, and this is so interesting because you see this in so many kiddos, a strong desire to control their environment, okay? You also see that in trauma, that need to control environment. Changes in routine, you know, attempts to control or comfort may not be well received by this kiddo. And because of all of that, they may not do well academically and they may not do well behaviorally in the classroom. Okay. So in the DSM, that's in 1987, the DSM-3 TR is, I'm sorry, the DSM-3 in 1980 is when it was first introduced, all the way to our latest model of the DSM, which is the 5 TR now, I think. Who knows? Could be 6 soon. So it was relatively unchanged all that time. And we had reactive attachment disorder, and we had two different subtypes. Let me see if that's in the next slide. And with the two different subtypes, we had inhibited and disinhibited, right? So with those two different designations, it identified obviously different behaviors presented by the child. So in the latest DSM, what they took a look at, right, is separating those two out. Because what they found research-wise was that kiddos who were diagnosed with reactive attachment inhibited type had a better prognosis if placed in a caring, loving home, not necessarily, being able to generalize all of those things. Oops, sorry.
You're fine. I can take care of that.
Okay, thank you. Sorry. So with the reactive attachment inhibited, they have a better chance of progressing in a loving and caring home. So if fostered appropriately and adopted, there's a good possibility of being able to become a productive citizen and be able to manage their life. Okay. But with the disinhibited type, that seemed to be more difficult. Because of that just going off that risky kind of behavior, engaging in risky type behavior, going off with unknown folks, some of the emotional withdrawal, the inability to connect, right? That they then decided through research or figured out through research that they can't really, they don't do as well once in a loving and nurturing home. If anybody has questions, please. Marlon, did you have a question? No? Okay. All right.
No.
Okay, thanks. So that's why they kind of made those two changes in the reactive attachment disorder. Again, it's the pathogenic care from the primary caretaker. You can have a primary caregiver, like a single adult, but if this individual puts the child in the car seat and puts that child in front of the TV, and then just kind of puts a bottle in their mouth and kind of, you know, rests the bottle on a towel so that the baby can drink it, there's just no interaction, right? Needs are not being met, and that child's not developing that trust in the world around them. Let's see, all right. Oh, I already did this. So the rationale was the studies found the differences in the persistence of children who had reactive attachment, disinhibited type compared to those who had inhibited type. So the disinhibited type persisted in demonstrating indiscriminate social ability into adolescence, even when they had formed a preferred attachment with new caregivers. Okay, so and the individuals diagnosed with inhibited type, when placed in a more normative caregiving situation, became less inhibited and no longer met criteria. So kind of what Dr. Lillard was talking about, we have that, you know, that fear that the prognosis is not positive, and what's going to happen, you know, when this kiddo gets into adolescence and gets into adulthood, right? So I think one thing in particular with reactive attachment is that when looking at it and diagnosing it, even though in the DSM it says that some of the criteria need to be met prior to age 5, folks seem to have a notion of like it can only be diagnosed from 0 to 5. And that in itself is not accurate. And I know, I think Dr. Lillard mentioned like conduct disorder, right? So what this makes me wonder is that if a kiddo has reactive attachment disorder and it hasn't been diagnosed properly, does this then lead to like the kind of that oppositional defiant disorder, right? To conduct disorder and to antisocial disorder, personality disorder as an adult. And we know that only 1 to 4%, right, of folks have antisocial personality disorder. So what are we missing? I think that's the piece for me, and this is an area, you know, of research for me. So I think a lot of this is around the fear to give this diagnosis as a practitioner. And also the fear that, okay, if I give this diagnosis, how can I help this kid? How can I help, you know, these parents with this diagnosis? And then thinking like, if you're telling a parent this kiddo might have reactive attachment disorder, what is their response going to be? You know, what is their response going to be? So it is risky. It's a little risky as well, because some parents could have the same notion that like, this is not going to get better. So maybe I need to back out now because I don't know what to do with this, right? And I'll be honest, a lot of people also think when they hear reactive attachment, that that's the kiddo who's, and forgive me for just giving such a blunt example, but like that's the kiddo who's going to be standing by your bed, you know, late at night, you wake up and, you know, something's going to happen. So, and unfortunately, and that's just such a misnomer, because these kiddos are responsive in the right environment and with the right treatment. And but it needs to be diagnosed and it needs to be addressed clinically as early as possible. So we have a tendency to go with like oppositional defiant disorder when they're little, you know, even autism, right? Even autism can be confused with this because let me go to a different slide. I'm sorry. I'm kind of going off I just like to talk about this stuff, so I feel badly. I'm not following my slides very well. So with autism, right, you have kind of like that socially, they may not be as engaged, right? Deficits in that social reciprocity. You can see that also in oppositional defiant, and you absolutely see that in reactive attachment disorder. So I think folks are more comfortable with ODD and ASD rather than looking at reactive attachment disorder. Any thoughts or comments on that? I'd like to get Dr. Swagger's opinion on that.
Well, I will add to the mix that
Okay.
disruptive mood dysregulation disorder is probably far outpacing the others at this point.
Yeah. Yeah, you probably put that like with oppositional defiant when they're little, then it moves to the DMDD and then conduct and then, yeah. Because that, I personally clinically have an issue with conduct disorder because I'm like, yeah, they meet the criteria, but why? You know, why do they meet this criteria?
I'll also say that that's for the disorganized sort of type too. Like there's a whole nother path that kind of goes down anxiety disorders and avoidant traits on kind of the more insecure kind of attachment type. So I mean, a lot of it kind of depends on the trajectory. And you kind of asked me what I first thought about when I heard reactive attachment disorder, and I didn't answer because I have a lot of feelings, and I think it's dependent on who uses the term, and what their perception is. But the other challenge, and I'm sure you know this with the research, but the other challenge is we don't have a good forward following of these kids to get great data on what they become. And so in order to do that, you do have to start with identifying it early and being able to follow it up. But I would say my experience is more that I see the 5,000 other diagnoses and then look backwards. And so I think all of the examples you gave, plus DMDD, PTSD, and a whole host of other, I mean, any psychiatric disorder, even disorganized thinking, right, and psychotic symptoms can fall under that too. So, I kind of think it's the great mimicker, is what I would say.
Thank you. I appreciate that.
I know one thing that comes to I guess two things come to my mind. One, as a clinician, I then worry, okay, I give this diagnosis, how do we treat it, especially if it's not really caught early? And then two, what happens to people with reactive attachment disorder when they become adults? At some point, do we not call it reactive attachment disorder and we put another label on it?
Actually, you can diagnose this throughout adolescence and also into adulthood, from what I understand. Oops, I did something. I was trying to admit somebody and I did something.
The other thing I think that gets lost in it too, because I actually view it as a treatable condition, but I'm probably a different beast in that regard. But you have different types of attachment with different people, and I think that's the other part that I'm sure you're going to get into. But like you can say you have reactive attachment disorder, but then you, as a clinician, you also have to evaluate the extent of it, because it's a spectrum of different degrees of attachment, and so it really gets misapplied as a term that applies to all relationships, and that I think is even more confusing. It's a diagnosis people don't have a lot of educational understanding of and are fearful of it as a result. But I'm with it is treatable. The caregiver is part of the treatment, and anything that abandons their disruption leads to the negativity, is sort of my short version, I guess.
No, I completely agree. It's treatable. And I think that's the kind of the reason I'm interested in doing more research on this and kind of practitioners' fear of diagnosing it. And I think it's such a disservice if we don't consider that. And I think typically what happens is we don't, as practitioners as a whole, I'm not saying anything specifically, but as a whole, I don't know if our assessments are clear enough, detailed enough, receive enough collaborative information, and that we can take a look at everything and not, we're forced to diagnose in the first session that we see somebody, which is so wrong, because particularly like with this issue or DMDD or any of those other things, you need time to figure this out. You need information from a variety of sources, and it makes it difficult. I mean, you can always do like a rule out of this and then, go back to it. But I think doing a very thorough, detailed assessment with all the information that you could possibly get would help to identify some of this. And I know, like in community mental health, in that first hour and a half, you have to have a diagnosis and a treatment plan and everything. So it just doesn't allow for, full consideration of everything, including reactive attachment.
Kelly, billing in the state of West Virginia does not require that. You can use generic spectrum unspecified codes. They do not require a specific diagnosis in the first session in any of the billing modalities.
Oh, great, thank you.
Some states, you're absolutely right, do, and if you don't
Yeah,
give one,
Florida
you
does.
don't-
Yeah, that's where the bulk
they
of
do
my
not
experience
pay, but
is. Yeah.
West Virginia, there is no there's no requirement for that. So I think it's important. So I think people, I think sometimes it's more of a clinician fear that of they don't know how to do it, or and that they don't have the time. But I don't see that in West Virginia as much as I think people just have no idea what to assess.
Okay, okay. And that's different than in Florida. You know, it was required within that first session to have a diagnosis and a treatment plan, which is just not feasible. So always you give the least restrictive, right? And then move on from there to figure it out. And I think too, we look again, most folks look from 0 to 5. Yes, you have to have some symptomology before age 5, right? But this can be diagnosed into adolescence. I'm currently working with a kiddo who I think that this may be a case of reactive attachment. And it's a kiddo who was adopted, so, but adopted young. And that's another thing I think practitioners think, oh, well, they, got into this home at whatever, 2 years old. So not a lot happened before that, is what a lot of people think. But pre-verbal, trauma, negligence by a caregiver, that is significant. And even we know now in utero what impact a parent, a mom has if like the pregnancy is not wanted, if there's a lot of stress, all of that. So there's so much more that we know now that makes it easier to really take a look at reactive attachment and say, hey, is this a possibility with this? So, and I think particularly, I think reactive attachment overlays with autism a lot because the autism spectrum has changed. Now it's a spectrum. Before it used to be 2 different categories. And I think there are a lot of interlocking or interlacing symptoms with both. So, and I think again, folks are just more comfortable, and because it's out there so much with autism, that they jump to autism. Not that I'm saying it's not it, or there isn't a large, increase in kiddos who have autism, but I'm wondering if this is kind of a factor too, right? I think obviously with reactive attachment, you're missing the, like the fixation or perseveration on a particular focus, area, for autism. But, I think those two overlap a lot, and we really need as practitioners to sort through that. Right. So to work in the best interest of that child and that family, so we can then provide them with services that will be helpful and that we're not missing the boat. So I think it was Dr. Lillard said, like, what do we do? People aren't comfortable because we don't know what to do then once it's diagnosed. The PCIT, the parent-child interaction therapy, I think is one of the first interventions if you have a younger kiddo, working with the foster or adoptive parents in addressing kind of making that connection. I know with one kiddo I'm working with, that's all I work on with the mom and the kiddo are attachment activities, like how to build that bond and with the dad, and really making that connection stronger. So sometimes it's a matter of really just engaging the parent and the child in an activity where they are facing each other, where they're hugging each other, or they're connecting in some way, physically, eye contact, whatever. So it builds that connection over time that they may not have because of that child's experience, in foster before being adopted. Child parent psychotherapy. Sorry, my voice is really, I'm just getting over strep throat, so I apologize. Child parent psychotherapy, both very similar to PCIT. It's on building that parental capacity for sensitivity and responsiveness, right? That parent is responding, and that helps to build that trust, right? That increases that bond, and then Also teaching, you know, assertive communication, some of the skills that you normally teach kiddos who are not reactive attachment, do not have reactive attachment, but those communication skills so you can build that strength with the family. Okay, and there are a couple others, the multifamily group intervention, right? And interaction guidance. I'm not too familiar with that. Like I said, I'm still kind of getting into the research with this. Video feedback intervention, right? This is always helpful. That because sometimes parents just don't realize what they're doing or what they're not doing. And this really helps them to understand how to make those changes. Okay. Any questions about that, the interventions? It's not moving. There we go. Oh. Am I only going forward? Okay. Can I go backwards? There I am.
Yeah, you can go backwards if you need to. Or go to
Okay.
a slide if you feel like you
Sorry.
no, you're fine. Because people
I
want
should have
to-
let you just put this and that would have been good. Would have been organized. Okay, so any questions about the changes? Why the DSM was changed to two separate categories? Okay. I think we went over this. DSM, yeah. So again, I think my main point with this and wanting to share this is to make practitioners just aware that this is out there. A lot of kids, even in homes where they have lived in that home, right? They're not in foster, they're not in an adoptive home. They're in the biological home, but that doesn't mean that they're being attended to. Okay, that their needs are being attended to, nor are their emotions being attended to, and that connection, that attachment. You know, we see that a lot in a lot of different circumstances, not just with substance abuse, but with parents with maybe depression, you know, severe depression, postpartum moms, right? Postpartum depression. So you see that happening in intact families. So again, being aware of that and being aware of needing to assess for that if a parent shares like they just weren't that involved with the kiddo. And also knowing that this can exist, right? And not be diagnosed until they're older. Typically when they're older, you see kind of the conduct type of behavior, right? The stealing, the you know, just destruction of property, different things like that you see with conduct. But as I always with conduct, I'm like, what's behind the conduct? There's something behind there. So let's find out what that is, rather than slapping on a conduct disorder that will then move to an antisocial as they get older. If they're not treated correctly and if they're not provided opportunity. Okay, so the prevalence of reactive attachment, it's more rare, and I think it's more rare because we just have a fear of diagnosing it. Okay, I think I went over that. Okay. Okay, so children diagnosed with reactive attachment, yes, they can, if they're in a caring and structured and consistent environment, can improve their attachment behaviors and can normalize over time. Children with the disrupted or the disinhibited type, they have continued difficulty developing attachments to new caregivers and have poor peer relationships. And prognosis is influenced by the duration and severity of the neglect and the degree of impairment that results. So obviously it's worse if the neglect was more significant versus others. So cultural considerations. Pictures are over. I keep having to move my taskbar here. Okay, so it doesn't seem to be gender or ethnicity to be a risk factor, right? Obviously more children who are in poverty related situations, right? African-American and multiracial children experience a higher rate of child maltreatment than their non-minority counterparts. So a larger higher incidence of reactive attachment disorder in minority populations. And that is we know that minority populations particularly have a higher, can live in a higher poverty level, which I think directly impacts this. And attachment is a universal phenomenon, and it varies with culture, right? Depending on the culture. And okay, caution is advised in making a diagnosis of reactive attachment in cultures where attachment has not been studied. Okay, so differential diagnoses, you're looking at autism, sometimes intellectual impairment, and depressive disorders, as Dr. Swagger mentioned. And comorbidity, cognitive delays, language delays, we see that a lot, just with neglect in general, right? Malnutrition, depressive symptoms, ADHD, ADHD. Some theoretical models, okay. There really aren't any pharmacological interventions that are indicated. I know, we have with ASD, obviously, even ODD, some medications that have been beneficial in helping to mitigate the symptoms. But as far as reactive attachment, there really isn't anything medically, or like a pharmacological approach necessarily at this point. So, I mean, I'm assuming like some of the medications that help with ODD might also help with reactive attachment, but I'm not a doctor, so I'm not going to say that. Oh, I just said it. But the old thing of like therapeutic holding or compression, the rebirthing, whole thing, reworking of the trauma is not recommended interventions. And there was a case of a 10-year-old girl. I think there were many cases of being smothered to death by therapists who were practicing the holding therapy. So that whole like rebirthing approach, not a good therapeutic approach to treating this. Okay, obviously this is, we're looking at attachment theory with this, and we're looking at the neurobiology involved. That's Dr. Lillard's end. And so again, wanting to look at strategies, theories that will help us to best help that child, to help that family to progress as much as that child can, much as they can. We went over that. There's no specific assessment that I know of yet. I don't know, Dr. Lillard, if you know of anything, but no, yeah, that's what the research indicated. There's like one attention focused coding system, or attachment, not attention, sorry. And then story completion task, but their reliability and validity, I'm not too sure about, so. And that's it. Any questions?
I would say Amanda Newhouse might be the one to ask about the attachment assessment tools. I know some of them are interviews, attachment's a tough one, I think,
Yeah.
in general.
Yeah,
And
I'm not aware of like a straight validated instrument that has predictive abilities, but there's definitely clinical interviews and sort of even just observing the strange situation sort of issue.
Yes.
I think I think the challenge, right, for the diagnosing and treatment is having it on your radar to think about as a disorder. And then, like one of the challenges I think, and I'm speaking for the medical people, I guess, in this regard is this is not this is a disorder of interpersonal connectedness. It's very similar to personality disorders when you're talking about adult pathology, right? It's not something that you view as a chronic sort of adaptation and coping style over time. It's not curative. It's not like a treatment's going to cure it. It's a intervention and an introduction of a perception of change and skills related to how you interact. And it includes, especially for kids, it requires the adult, like you said, to also have ability to mentate and adapt and appreciate someone else's perspective. So, I mean, you're teaching both social skills, interpersonal communication skills. And those lines, when you compare them to other disorders, many disorders that have problems with attachment without having attachment disorders or social problems or interpersonal difficulties that you can see as well. And so from the treatment perspective, using tools or techniques that assess people's social skills, interpersonal communication skills. I mean, even with some of these kids, you don't even know what their basic language capability is, or their IQ may be to interpret what their level is. And so, I think to really assess it is looking at not just one dimension of it either. And so I think that's what makes it also notoriously challenging, because it's a mimicker. You have to rule out other causes.
Mhm.
You also have to do these in-depth sort of interpersonal and coping skills assessments regarding needs, because and you have to do a lot of observable data. You get very much into sort of behavioral analysis and how you watch those interactions. And so, I think the key component just from a clinical perspective is to step back and watch people interact, or to get enough examples regarding that interaction. You can identify opportunities to improve those things. I mean, that's really what PCIT is, right? It's giving parents a tool set, but helping them adapt in the moment with what that tool set is. And so that's why sort of PCIT works, but it's not magic. It's actually giving skills. But I mean, those are skills that aren't unique either to reactive attachment disorder. I mean, there's lots of utility that those things have. I think it's for me, and I've talked about this in other sessions before, it's a pivot in treatment from an individual focus into a community or parental unit, caregiver, dyadic focus, if you will, that is a pivot shift in how you approach care that isn't your traditional medical model. And so, at least on the medical end, it's a challenge to get people that are sort of kid people sometimes on board with that.
Yeah.
So
Yeah. Well, thank you for that. I think, absolutely. That's why I said there was really no, that I knew of, any kind of medication. I mean, with ODD, other things there are certain medications that kind of help, stabilize behaviors, but, and I don't know if that would be something with reactive attachment, depending on the behavior, but.
So much like autism, there's going to be no medicine that's curative to the direct cause of the symptom, right? But you can still use symptom-based approaches to care. I mean, if you have people with severe impulsive aggression, regardless of the cause, there are medicines that treat severe impulsive aggression across a variety of DDI, So, I mean, you can still target symptom things. I mean, you can see severe hyperactivity in trauma, ADHD, and just hyperarousal states related to anxiety. There are medicines that target underlying hyperarousal that contribute to hyperactivity that aren't always just for ADHD too. So, this medically, you can look at things as a diagnosis, this is a treatment, but you can also look at sort of evidence-informed symptom related treatment too. And I would also say, and I don't actually know the details on this, because I think it comes back to what you said about research, but I've never seen the diagnosis of reactive attachment disorder in isolation. Like, there are definitely other disorders and comorbidities associated with these. And so while the reactive attachment disorder may not be treatable, maybe they have a sleep condition, maybe they have some active PTSD symptoms, maybe they actually have ADHD. I mean, so it's not dying. I mean, you have to rule other things out, but it's frequently comorbid with a depressive episode or a variety of other things. So, I can sincerely cannot remember ever seeing one diagnosis on any child. I don't know, maybe Colleen or you have, and I don't know again if that's a fallacy of not catching it early enough as the cause, or, but I've never seen that.
Well, I know.
I mean, I might in spite just put reactive attachment just to counteract the fact that previously they've been giving 75 other diagnoses, including conduct disorder and ODD, and now Dr. Swiger can't place them anywhere in the state. And I did that recently. I said just PTSD, and I said all this other crap is just PTSD.
That's okay.
Mhm.
So, I like those are easier, Colleen.
So maybe in spite I would do it, but I mean, you're right. It's hard. And I think sometimes as providers, we just have to say this diagnostic picture is really muddy, but let me tell you what behaviors I'm seeing that I'm concerned about. And let's maybe stop worrying so much about that label.
Yeah, I know. In Florida with Medicaid, you could not have reactive attachment as a diagnosis. It was not reimbursable. So even if you thought that might be
Sometimes West Virginia does things well.
We have a win. We have a win.
Yeah.
Win.
We probably have higher rates of reactive attachment disorder as well.
I don't know. Okay, any other questions or comments?
I have a question.
Mhm.
You went into a little bit, going into like different modalities and stuff like that's going to help us, like, working on with families that are experiencing or the child has reactive attachment. For me, just hearing this is a great reminder to be thinking and be cognizant of early attachment and the reactions that tend to come with maltreatment and abuse that happens early on in childhood, and more so than like the diagnosis, when we're seeing children with ODD, or we're seeing children, that are more withdrawn, things like that. But my question specifically though is, when we have a family, let's say that is resistant, so we can say, hey, like, this treatment model is going to help, if we can build some of that attachment, we can work on it in that way. But a family that is, maybe kind of the creator of this, that is more resistant to working on their attachment and working on some of those issues that are happening for the family.
So what do you do in that situation? Unfortunately, we do see that a lot, not just with reactive attachment, but in a lot of other disorders as well. I think just trying to engage them at whatever level you can, and then working with that kiddo to try to build, their self-esteem, their self-confidence, their ability to manage what's coming up for them. And hopefully with that, the parent may see some progress and be willing to join in. I mean, it's possible that parent will never join and never be a part of that. And that's hard as a practitioner, right? Especially when we work with children, because we know how much of it, the treatment revolves around the active participation of the parent. So sometimes, and it's just working with that kiddo then and planting that seed and hoping that it grows. That's kind of the hard part of working with kids, is the parent component if you have a non-compliant parent. So, that wasn't a great answer. I wish I could wave a magic wand and say, ding, you're going to be involved, parent. Mhm.
Yeah, I mean, I think that's an excellent point. And I sort of want to throw, I mean, also I will say as a clinician, I've never given a single diagnosis of ODD. I've removed plenty because I find many other explanations. When you look at the diagnosis of ODD, it's really a disorder in the beholder of the caregiver in many ways, right? They're assigning blame to behaviors without an understanding of behaviors. And it's not, if you look at treatment algorithms for ODD, it's the same thing. It's all dyadic work, parent management, sort of, but, I see the ODD term also used very pejoratively, like it's a blame issue. The child is born that way. They are just oppositional, or my least favorite word, they're just manipulative. Well, manipulation is a feeling. You have to allow yourself to be manipulated. Oppositionality is again a state of perspective. It's and when you look at like work with child and adolescent psychiatrists, I'm not alone. Most people remove the diagnosis because that's not the primary explanation. Again, I'm probably seeing way more complicated kids, but it goes back to, when you isolate diagnosis within an individual and not understand the greater context of the family unit, or that there's an interpersonal, I mean, there's absolutely an interpersonal perception component to that ODD diagnosis, right? 100% that, you can't move forward in anything when one person's the victim, especially when it's a minor child that really does not have any cognitive skills or skill set, and the adults are blaming the child. You fail if you start there. And I think reactive attachment disorder very much that way. And that's the risk of the diagnosis. Oh, it's just forever. There's no hope. It's the hope, it's something that the child's, and I think culturally, I've seen people, if you do not provide the education when you give that diagnosis, they just go Google it, and then they call their child a sociopath, and then they need them sent away. So, I think there's a responsibility, not just about that, but how long does it take to really psychoeducate about the diagnosis of reactive attachment? It takes hours. You have to sit down and spend hours going through that process with people to understand what it means. And so, I think that's part of the time fear of clinicians. If I give this diagnosis, I know I have to sit down and explain it for hours and hours and hours because they're going to go Google it and it's going to cause more problems. Absolutely, yes. So, you know, like I think that's part of something to just kind of think about, you know, and if I gave that diagnosis, I booked off an hour in my schedule. I billed an hour actually of psychotherapy and psychoeducation to actually do that, and spent an entire time. And sometimes I had to do another one. And so I think when I think about like the treatment planning for it, I think you always have to start with that.
No,
Also-
I agree. Yeah, I agree. And sometimes, you know, parents buy in initially, but then they get back into the home where all the behavior's happening. They're like, no, 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 this is not it. This can't be it. And then it's like starting all over again. Yeah, so it's a lot with families. Family work is difficult.
I really appreciate your answer, both you as well as Dr. Swagger. And I think it's definitely hard work. Because it does. It's even if it is a foster child or adopted child, you know, looking at the interpersonal relationship there and how it's you know, we obviously look at like the parents and you know over the child, right? And how what you know the relationship that the parent has with the child and the impact that has. But also, unfortunately, especially with the parent is, you know, has less, you know, emotional intelligence, like they can get pulled into that cycle with them and start going into it with it. And then we see that different like shift there. But anyway, it was a great answer. There is no great answer for it. And I think that is the, the conclusion. But it's just nice just to hear that, because that is a hard one when you come up to that, like that barrier and trying to figure out ways to work with what is given. And I think I don't like that answer, right? To work with a child. I always say that, you know, it's giving the child a gas mask when the house is on fire, but sometimes that's what we got. And if that's what we have, that's what we have.
Yeah,
So I appreciate your
absolutely.
time for that.
No problem. And I think, you know, too, it's being able to join with that parent. You know, there's a special kind of finessing with it that you're joining with them to understand their perspective and what they're going through and acknowledge that and validate it. But then also remembering that, you know, this child is maybe behaving this way because of A, B, and C, and that it's not personal, because so many parents take it personally. So it's really trying to work conjointly with the parent, but also holding strict, you know, boundaries with what you're providing for the child. So yeah, it's a fine line.
And I'm not sure. I have a question. I read a lot of articles and I can never remember where I read it, but I read something about like parent management engagement like strategies, and I think it incorporated like ODD and even autism, and but that theme of kind of mentation, that the success, right? When you looked at who had success, parents who had success, it was the ones that had the ability to understand the perspective of the child. And that was really the sort of defining moment regarding prognosis. And so, you know, I don't know if anybody remembers what that article was specifically about, but I saw this article where that was the sole predictive factor of success was the buy-in the parents had to understand that perspective of the child and maybe attempt to address it. And I wish I could remember. Does anyone know what article I'm talking about? I remember being like, yes, that is so true, but I had never seen it that way. So
But it is true. You have to really have those parents on board, and you have to, you know, build trust with them too. So it's, you know, it's not just the kiddo you're building trust with and rapport with, it's the parents, and that you're validating what they're saying and they're feeling, you know, also validating what the kiddo's feeling. And oftentimes I'll say, well, this is the perception that the kiddo has of the situation. So that it doesn't directly kind of blame the parent, you know. So let's talk about that perception that child has and why. So it's a little bit gentler, you know, so you're not saying you're doing this. So, so it encourages conversation, hopefully. Any other questions or comments?
This has been one of my favorite echoes. I think
Oh,
out of all of the echoes I've ever attended so far in like almost 2 years. But it raises a lot of questions for me, because here at PBS, and I don't know if you know this, but I do what we call triage. So I'm like the first person to talk to our families coming in. So I'm seeing those diagnoses, which is often 4, 5, 6 different ones. And we've talked about this in different echoes, past echoes, about how many younger children are continuously getting ODD over and over again, when the perspective is there. Like, are they really oppositional? Or are they really just being for and exercising
Mhm.
independent thought, right? Like, is that? But I think what's interesting is too, in addition to that buy-in piece, is almost like that epigenetic piece. Like, is the parent even capable of creating that type of attachment? And where is their trauma at? And how far back does that go? You know, when we think of like that neurobiology piece of, attachment. So this is just making my brain just go bing, bing, ping, because I love this topic. And so anyways, thank you so much. I think we have a big, we definitely have a big like subject group here in West Virginia to pull from if we ever wanted to do some kind of big study, because we have a ton of kids that I think do have that diagnosis that we're not seeing. And I'm not credentialed to diagnose yet, but I know, I just, it's there, and it's got to be that underlying reason why we see so many of these challenging behaviors. So
Exactly. And seeing it also into adolescence, I think is the point to remember as well, not to just jump to, oh, this kid is conduct, so looking at that history. So I think that piece is important too. So thank you.
I know Colleen had to jump off, but conduct disorder is far more the kiss of death and getting
Oh, gosh,
services
yes.
than reactive attachment disorder. So
Yeah.
at least in West Virginia,
I wish that could be removed, because every time I see it, I'm like, okay, what's behind that? Come on, let's do a little bit more digging, more assessment. It's not just, this kid doesn't just act this way for no reason, so I
I
don't know.
call those the lazy diagnoses.
Yes,
Just
exactly.
straight up lazy if you're giving
Mhm.
out conduct and not thinking of anything else. Lazy.
Exactly. And it doesn't help the client. It does not help at
We're
all.
putting so much more responsibility on a child to be in control and manage their emotions and the adults and their like environment around them, which is absolutely insane. It's so much easier to say, oh, no, it's them. This is,
Yeah,
we can just talk
absolutely.
about this all day, but like,
I know, right?
definitely.
Oh, can't hear you.
See, I do this for years
There?
and then excellent job, everyone. Thank you so much. It's been a
Thank you
great
so much, Dr.
topic,
Scott.
great discussion, very lively, really appreciate it. And if you have a case and you want to discuss somebody, obviously not the name, but discuss it
Yeah.
in a future
Mhm.
echo, we can do that. The next time we meet, since we have about 2 minutes left, my only announcement is that Dr. Lillard will be discussing on the 21st. It's going to be school to prison pipeline. So we look forward to that discussion. That'll be really interesting too.
Talk about conduct.
Oh, more,
Yes.
yep, exactly. So it'll be good. If you guys need anything or have any questions, please feel free to reach out, and I'll see you next time.
Bye-bye. Thank you.